With your hosts, Lily Mundy, Raj Parikh, and Kyle Sanniec, this is the award-winning PRS Journal Club podcast.
Hi everyone, and welcome to the August 2019 edition of the PRS Journal Club podcast. I'm Raj Parikh, PRS Resident Ambassador from Washington University in St. Louis, and I'm joined by my co-resident ambassadors, Lily Mundy from Duke University and Kyle Sanniec from UT Southwestern. Today we have the honor of being joined by Dr. Justin Sachs, Vice Chair of Clinical Operations, Director of Oncological Reconstruction, and Associate Professor of Plastic and Reconstructive Surgery at Johns Hopkins University. Thank you so much for joining us, Dr. Sachs, for this PRS Journal Club podcast.
Thank you so much for having me.
The articles that we will discuss can be read for free on prsjournal.com, including an archive of all past Journal Club articles. The next article we will be discussing is A Growing Epidemic, Plastic Surgeons and Burnout, a Literature Review from Dr. Jeffrey Janis and his group at Ohio State. This article is a systematic review that evaluates the prevalence and consequences of physician burnout, specifically focusing on plastic surgeons. In this article from Dr. Janis and his group at Ohio State, they evaluated 65 relevant articles on burnout in physicians in general, and then focused on surgeons and plastic surgeons specifically. On their literature review, they found that commonly reported rates of burnout range from 29 to 55%, with plastic surgeons coming in right around 29 to 31% in a few different studies. This study, they defined burnout with different measurements and really reported in those instruments that are used to measure burnout in Table 1. And they look at burnout, depression, and quality of life. And in most studies on burnout, they used a Mouse-Latch burnout inventory, which talks about emotional exhaustion, depersonalization components, and this high score on that correlates with burnout. And that inventory really focuses on three main elements, which are emotional exhaustion, depersonalization, and then a reduced sense of personal accomplishment. And then each of those is really defined further in this paper. When they look at the point of view of an employee or a worker, they talk about burnout developing when a lack of control over the job environment. And that's really the most powerful predictor of burnout. What the authors also look at is what are predictors among physicians and then plastic surgeons in general. Risk factors for physician burnout in this study included increased workload and call, junior academic rank, and fair physician health. And among plastic surgeons, they looked at an excessive work week greater than 70 hours per week, or greater than 2 nights of call per week, microsurgical or aesthetic subspecialty, junior academic rank, and a salary less than $250,000 were all associated with burnout on this literature review. Furthermore, and interestingly, a salary greater than $750,000 was also associated with burnout. Protective factors appeared to be having children in the previous studies. The authors also emphasize some of the consequences of burnout and then how it coexists with depression, alcohol abuse, and substance abuse. While these studies were limited specifically in the plastic surgery population, there was a self-reported study that they covered where 15% of plastic surgeons screened positive for physical and mental impairment, 8% for alcohol abuse, and 5% for substance abuse, so still very concerning numbers. And then broader in the American College of Surgeons, even higher. So they talk about the consequences of burnout also impacting physical, intellectual, and mental health. And really what the authors aim to do is provide an algorithm or a template that can help physicians prevent burnout and then also manage it if they're experiencing it. And they focus on 3 critical components, and that's improving physical health, improving intellectual health, and improving psychological health. And that's really the key, and they really expand on these each in more detail as they go on in the article to really cover some of these critical topics. So with that, I really wanted to get your thoughts, Dr. Sachs, on this paper as a whole, and then on the concept of physician burnout. The authors really report the prevalence of burnout, and it continues to rise. Anecdotally, is this something you've witnessed in your career as a plastic surgeon, and then what factors do you think are responsible for burnout among plastic surgeons?
So I think this is a great article. It's a timely article, and it's something that's not just sort of affecting our society of plastic surgeons, but it's affecting, all of healthcare, medicine and surgery and all related fields. Have I seen this in my career? I was a resident and a fellow and a research fellow for a total of 10 years, medical student for 4, and I've been faculty now for 10. So 24 years of doing this at a rigorous level. And I've seen people in a burnt out condition. They've verbalized it. I've witnessed it. Even myself as a busy surgeon who operates, who does research, who has a family, who has administrative roles, the stresses and strains of an academic or any kind of practice, surgical practice, can be daunting for yourself as you move forward. So without a doubt, I witness it in colleagues that I work with. Delayed signing of operative notes and clinical notes, not responding to emails over time. Complications rise up a little bit more at certain points in the year. I don't know if that's necessarily the sign of it, but I think those are the symptoms of sometimes of people that are overworked, potentially perceived as undervalued, either in how they're perceived professionally or even financially. What do I think is responsible for the burnout among plastic surgeons? I sort of try to stop burnout in myself all the time. You can lose control, as what the article said, that lack of autonomy, that loss of control. And I think that the ability to perform at a high level, to take care of patients, to operate, to do things that we, as plastic surgeons, we create stuff out of nothing. We reconstruct both form and function, taking tissue from one part of the body to the next. Cosmetic operations, making people look beautiful to themselves and others. And you layer that on with administrative burdens, electronic medical records, the cadence of EMR, the deadlines, what you have to do, and then take that and put that in relationship to having a normal life with significant others, family, social events. So I think you put that all together and you're in a situation now where we as a society have to understand that you might have people smiling, but underneath they might be in a different state.
I think those are all excellent points, Dr. Sachs. I think Dr. Bentz, and I encourage everyone who's listening to the podcast to read his discussion article as well on this paper. I thought it was he made some excellent points as well. One of the things I wanted to get your thoughts on, Dr. Sachs, is the authors identified increased workload, call responsibilities, junior academic rank, and low starting salary as all important in plastic surgery as contributing to burnout. In an academic practice, it seems almost impossible to avoid some of these risk factors, specifically the workload, call responsibilities, and starting at the junior rank. From your experience, what advice on preventing burnout or managing burnout do you have for plastic surgeons at the early part of their career?
Here comes the cavalry, right? I should be burnt out based upon all these things. Academic practice, reduced financial remuneration, increased call responsibilities, not so much a junior academic rank anymore, but I know what it's like to be there. I think that the things that you have to do as chief residents and fellows and junior faculty is you have to create structures where you have control over what's happening to you at work. And I think for those of us who are surgeons, we love operating. And being in that operating room is what we all train to do and what you're training to do now and what you will do, on a daily basis. The problem with operating is that it takes you away from some of the stuff that's going to hurt you, such as electronic medical records, academic research, clinical and basic science research. So you have to balance everything. So what you have to do is you have to create time for yourself to do those things. The most important word that you have to remember from this podcast in order to help prevent burnout is you have to be able to say no to certain things. And you have to be able to set guidelines for yourself. So you have to be able to say, I can't do that because I have to do something else for myself, such as whatever it is, exercise or see a friend. The other thing you have to do is electronic medical records. I'm telling you, you have to get control of it. Does everybody use EMR on this podcast that are asking me questions here? Right, so EMR, if you are typing your notes and you are not smart setting your notes or having a formalized way to do this efficiently, you are going to get hurt. As you have busy clinics, as you have busy cases, and you start to do 5, 10, 15 operative cases a week, as you see 20, 30, 40, 50 patients in a week, you have to manage the EMR. We use Epic at Johns Hopkins. There are smart sets that you can use to template your clinic consultations. There are smart sets to template different procedures and patients that you'll see. Scribes, the ability to have the hospital or your practice bring somebody in who has dedicated time, either as a full-time job or maybe at Johns Hopkins where they're pre-med students and they decide to take the year off and they scribe. They say what you say in the clinic room, your life will change. You will have control. For example, my clinic I do breast reconstruction in clinic Wednesday afternoon. I see about 20 patients, and on Thursday I have general reconstruction clinic, see about 30 to 40 patients. So that means that I'm seeing over 50 patients a week. Those notes on top of 10 to 20 operations a week, you have to get them done. And I scribe now. I bring a scribe into my clinic, and when I walk out of clinic, those notes are done, and I have to review them and edit, which is a lot different than creating them from de novo. And I think these are the things that you have to do. You have to come up with ways to gain control over the work you have to do. And if you gain control over the work that you have to do, it be the institution supports you or your practice supports you, then you will gain control, and then you will have less of a feeling of quote-unquote burnout.
I think those are excellent points, Dr. Sachs. I think the concept of control is definitely important, and I think what you mentioned is key, is finding ways to have control regardless of where you are in your career and some of the external factors, and making sure you're at least in control of what you can be. Lily and Kyle, I wanted to get your thoughts. At your institutions, do you have any formal or informal training on burnout and preventative measures? It seems that part of the GME nationally pushes to make this more of an emphasis. So I just wanted to know, have you seen more of a shift in that? And then is there more of like things like resident retreats, or is there any institutional support for some of the factors on avoiding burnout, such as physical health, psychological health, or intellectual health?
Here at Duke, I've noticed a big change, I think, just in my time as a resident here. Within our plastic surgery division, we've had a grand rounds on burnout and started to develop, what we think would be helpful and practical things for us to do sort of during our didactic time. And then our GME and our overall medical, our residency group here at Duke has started to do a lot of things and trying to really identify ways that they can provide us with resources or, free food, or if there's just different scenarios that they can do to try to intervene on to help with burnout. One of my biggest takeaways from our grand rounds that we had on burnout recently was a lot of people have this preconceived notion before really getting involved and learning more about it, which I think this article does a great job of providing education, that people early on in their career aren't, quote, entitled to feel burnt out because, medical students or early residents, they haven't been doing this for long enough to feel burnt out. And I think that's something that when you think about why people feel burnt out, and one of the biggest things is this concept of autonomy, and medical students and junior residents probably have in many ways the least amount of autonomy over their own time. And so I think articles like this are great because we can talk about it and become more educated about what the risk factors are, and so we can try to help intervene and recognize people that we're working with on a daily basis that are experiencing burnout to help prevent things like medical errors and things like that.
Kyle here. At UT, we do have both formal and informal burnout sessions or wellness sessions, whatever you want to call it. I think it's been a mixed bag. I think some of them have been very much directed by the institution, the university, and in my experience, those aren't as applicable to us because they're kind of all over the place in terms of just generalized things. But the more focused, informal ones with faculty one-on-one has been what's more helpful for us, I think. I think talking to other residents, not just at UT, but throughout the country, a lot of them talk about the disconnect between the burnout sessions or the wellness sessions to the point that it almost seems like you're just trying to check a box for the ACGME rather than actually implement strategies that will fix burnout. Like Dr. Sachs mentioned, this inability to control your autonomy or control your clinic or control how you want to treat patients. And I think that's probably the next step I would really love to see people tackle in terms of burnout, is looking at what can they actually implement, not just, a lecture and, some warm cookies, but what can you actually implement in the clinical setting or in the administrative setting to decrease the risks of burnout? And I think that's the next step. And we have a lot of articles on physician burnout and plastic surgeon burnout. And so we know about it, but now what are we going to do about it? I mean, that's where I'd love to see the next stage of this research kind of go.
Kyle, those are great points. And I think, you mentioned, at Johns Hopkins, we have a resident and faculty ACGME annual wellness survey. And actually for the past 2 years in a row, we've had our retreat has brought in speakers to discuss burnout and identify it and come up with strategies to deal with it. But it's really something that has to be more than just having a yoga center or having a gym there. It's really stuff that's going to have to go into sort of the system approach to how medicine is provided, especially as the electronic medical record becomes more fundamental to everything we do in practice. So the things that I did mention, the scribe, Recently at Johns Hopkins, over the past couple years, they bought us Dragon dictation. So, for example, my operative notes now are done literally after pretty much the operation is done, and while the patient's being woken up, I will be able to drag and dictate my operative note, which has really changed my life. I'm just, as an example, I have 2 children. I have a 13 and 11-year-old, and everything I do every day and every week the goal is not to bring work home. I could tell you horror stories of myself and my partners who are up 2, 3 o'clock in the morning doing notes, trying to beat deadlines. But what's happened to me in the past year is with a voice dictation system, not to use Dragon specifically, I'm able to stay ahead of the medical dictation. When I come home without any notes to do, I am a normal human being again, because I can engage my wife and my kids, and I can do stuff that I normally wouldn't feel stressed to do because I'd have those dictations or notes in the background. I think as residents, I don't know how much of that stuff you have to do yet, but as you transition to where I am, where you're going to be busy operating, where you're going to be busy seeing patients, where you're going to be busy doing research or administrating or not, once you get that control, you'll feel less stressed, the anxiety levels will go down, and then you'll be able to hopefully feel less quote-unquote burnt out. So I think it's not just us, it's the institutions that we work at that have to create systems that give us the tools and the technology and the resources to help us truly feel in control, and not, as you said, Kyle, warm cookies and some lectures.
Thank you so much. Yes, I agree completely, Dr. Sachs and Kyle. I think those are all very excellent points, and it's really just a commitment, I think, from organized medicine, organized plastic surgery, our institutions that we're part of, and really the push should come from people like in the practice, plastic surgeons at the ground level who can go back to the institution and say, we need support for this or we need support for that, and then really tell your colleagues and your friends that this is something that's made my life easier. And I think that speaks to kind of the collegiality and the positive relationships you can build with others, one of those components. But really, I think that's a big key, is just having a network and sharing ideas on what's been beneficial. And I think the hope is that, at least some people listening would get some benefits from listening to this or from the article itself, and definitely from some of the discussion either here on the podcast or with Dr. Bentz. Did anyone have any last thoughts on this article?
I want to bring up another point before we go, and the article talked about finding a mentor, and I think that's a critical thing to do as junior and mid and even seasoned career plastic surgeons. It's always important to have somebody out there who's been there and done that and has survived well, because you can model that behavior either by watching it or asking about it. And I think we're not alone. Nobody's alone in this profession. We are a society, we're colleagues, and I think it's important that you reach out to people who've done it and ask those questions. How do you manage the daily grind? How do you manage the work, and how do you manage the stress? Because I think you'll learn stuff from those questions, and I constantly learn by asking my colleagues how they do it, because I'm always trying to be better and to try to be more in control of what I do so that I can be happy for my patients and happy for my family.
For all of us, and I'd recommend all the residents out there too, to do exactly what Dr. Sachs said, which is to find somebody you can count on as a mentor, find some colleagues, find a network, and really take advantage of that. I think with that, we will end the discussion of this article. Thank you everyone for a great discussion. If you like this podcast, please feel free to share it with your colleagues and friends and rate us on the Apple iTunes Store. Also, remember to tune into the other 2 articles that we will be discussing on this month's podcast. Finally, please join us for our monthly journal club on Facebook, where we'll be able to interact directly in real time with this month's selected articles' authors. Go ahead and like the Plastic and Reconstructive Surgery Facebook page if you've not already done so. It is where our monthly journal club takes place. And once again, thank you so much, Dr. Sachs, for joining us today.
My pleasure.
Thanks for listening to the award-winning PRS Journal Club podcast. Please click, subscribe, and leave a ratings or review if you're enjoying what we do every day.